I will be discussing remote diagnosis and monitoring in this video. These are my financial disclosures. Globally, there are at least 2.2 billion people who have visual impairment or blindness, of whom 1 billion have vision impairment that could have been prevented or has yet to be addressed or identified. Glaucoma and diabetic retinopathy are two of the four leading causes of blindness, are on the rise worldwide and in the USA. It's predicted by 2050, the number of individuals with glaucoma will rise to over 6 million, and the number of individuals with diabetic retinopathy will rise to over 14 million. That being said, 50% of people who have glaucoma in the US don't know they have glaucoma, and it's up to 90% in other countries worldwide. The COVID pandemic brought in challenges and opportunities. And to me, for telehealth is like crossing the Rubicon. Our colleagues were very innovative during the COVID pandemic. They sent visual acuity card and Amsler grids. They had drive-through IOP measurements, and they created hybrid visit. But in reality, it showed our deficiencies in taking care of our patients remotely and monitoring them. We need digital disruptions to change that. In our institution and in my innovation lab, we started looking at different ways to address remote monitoring during the COVID pandemic. We looked at apps similar to visual acuity apps. We looked at different types of technology to measure intraocular pressure and a visual field. We created a quick and dirty app to check vision in our lab and send it to our patients. And the reason is we noticed that the apps that were on the market at that time, you were able to zoom in and out, so the accuracy is questionable and it does not connect to the electronic medical record. So we started mailing the devices to patients. We created a virtual training visits, and the patient would leave the device for approximately a week, measure the pressure 6 times a day. They would mail it back to us, and we would have a virtual visit with the patient to discuss the results. In addition, we reached out to our institution to build a robust build for our vision app that we created based on the Rosenbaum card. We created 2 versions. One, it's free on the App Store or the Google Store for anybody to use, and one that is connected to our electronic medical record. When the patient is waiting in the virtual waiting room, they can check their vision, and once it's done, it directly populates into EPIC, our electronic medical record. In addition, we wanted to validate our vision app and compare it to the Rosenbaum card. We did 240 eyes and looked at the agreement, and it had good agreement on the iPhone and the Android. These results were published, were presented in AAO, and the paper is in submission. In addition, we wanted to look at the home monitoring devices to see the acceptability. We did a qualitative and quantitative analysis for sending a virtual reality visual field and home eye care tonometry to patients. We wanted to understand the acceptability and the feasibility and do preliminary data to compare to the Humphrey visual field to virtual reality visual field. Because the home eye care tonometry, there's been a lot of studies validating it. And we took 20 patients with ocular hypertension or glaucoma. We sent both devices to their home, and they kept the devices for approximately a week. They measured the intraocular pressure 4 times a day and the visual field 3 times a week. We looked at the acceptability, and 73% felt that the home tonometry was easy to use. 100% found it useful. 100% felt the visual field was easy to use. 94% found the visual field device useful. 100% of patients were able to obtain acceptable IOP and complete the visual field test. 98% of the total home tonometry measurement were acceptable. We had 19% anomalous visual fields on the virtual reality visual field, but this is not uncommon as Humphrey visual fields have high anomalous rates, especially early on in the studies. We identified 3 themes for the home monitoring. advantage of home monitoring, difficulties with home monitoring, future consideration for home monitoring, and the patient's experience. I've been in practice for 18 years, and I never understood that there is a problem with connecting with friends and family for patients. They said their family members better understood what they had to deal with. In addition, a lot of them were not happy that they were not able to see the results and the data. They requested that there should be patient education as part of the package, and that they usually have IOP anxiety. We have white coat syndrome for blood pressure. Do we have white coat syndrome for IOP? In addition, as mentioned in my prior video, within 4 months, we performed over 1,500 virtual visits. So we wanted to evaluate the results from the virtual visit from one of our sites, 780 patients. So we looked at the similar diagnosis. There is a change in the diagnosis after they follow up. 83% had similar diagnosis. Treatment plan was maintained in 50%. But just to attract your attention, a lot of the patients that had virtual visits had chalazion, blepharitis, or oculoplastic complaints. So that's why 50% treatment plan were maintained. In addition, we had 3.8% error. And what's important, 38% escalation in treatment in glaucoma, and that's based on the home eye care. With the virtual reality visual field, we had 2 patients with changes on the visual field that we brought them back to be evaluated, and they were true changes, and we escalated treatment. Now, that being said, can we bill for remote monitoring? Right now, there are remote monitoring billing codes, and it pays for setup. It pays for monitoring for 30 days for each device. And you have to discuss the results with the patients for more than 20 minutes or write communication with the patients. It could be used for anything: IOP, weight, blood pressure. The problem in ophthalmology, it's not easy to break even with this model, as our devices are very expensive. So to be able to pay off the home eye care tonometry, you will need a few years if you use these codes. In our practice, we actually rent it to the patient, and the patient pays out of pocket. So the future is here, and it's going to be even better. We will be utilizing apps, devices, to be able to evaluate patients, measure their pressure, and do functional and structural testing. We could have OCTs at home. Maybe we can connect it to the Apple Watch, and patients will be able to self-monitor. And on top of that, we will have to use artificial intelligence to identify change as there will be a lot of data that we will be collecting, and it's hard for us to evaluate it. So artificial intelligence might be there to help us identify the patients that are progressing or need to be brought to the office sooner. So in conclusion, remote monitoring is here to stay. Remote monitoring shifts chronic monitoring to the patient's home. New models of care are being created, incorporating telemedicine and remote monitoring. We will have better understanding of patients' disease to the frequent and continuous monitoring of disease. Remote monitoring devices are the future. Thank you.